Hello everyone. Today we will go through the general questions in anatomy for electrophysiologists, for allied professionals, and just basic questions, anatomical questions for electrophysiology. So anatomy is a background for us, for electrophysiologists, because we actually understand that all signals which we register and then can create the different maps actually create by anatomical structures. That's why we really have to carefully understand all the anatomical structures. I will explain all anatomical details on these specimens, which is plastinated human heart specimens. So this is real hearts. And first of all, we will discuss position of the heart in the thorax. As you can see here, this is a so-called Valentine position. And then from this position, we can see the right atrium, right ventricle, left ventricle, and the left atrium. This is our normal anatomical nomenclature. Unfortunately, this anatomical nomenclature actually not really explain the real positioning of the structures in the thorax. Now you can see a P projection. So this is a real heart positioning in the thorax, and as you can see, the right ventricle, actually mostly anterior ventricle, and the left ventricle, posterior left and posterior structure. At the same time, right atrium, anterior atrium, and as we can see here, the left atrium is the most posterior structure. Let's discuss a little bit about the projections. We will discuss later in our third lecture the fluoroanatomy, but now we still need to discuss this a little bit. So when we make an aerial projection, then we will see heart in this manner. We can see superior vena cava, right atrium, atrioventricular groove with the right coronary artery. This is a right ventricle, and in this projection we can better recognize the position of the catheters and the structures compared to AV groove and apex, and of course compared to a posterior side of the atriums. In the same time, if we turn to the LAO projection, then we will see the structures and compared to lateral walls, right and left ventricle, or right and left atrium, and compared to septum. Now I will take this endocast. So this is very important also to understand how looks like the endocardial surface. So this is a so-called endocast where we can see how looks like endocardial surface in different parts of the heart. And again, this is our AP projection. We can see right ventricle, which is mostly anterior, left ventricle, which is mostly posterior, right atrium, and left atrium. Again, if we turn it in area projection, then we can see right atrium, right ventricle, pulmonary artery, and we can understand better compared to apex and AV groove. And then in LO projection we can recognize better structures compared to septum and lateral walls of left and right ventricle. Already now what we can see that the septum pretty often can be found in anatomical books like just a straight structure, but you can see already here, especially in endocast, that this is somehow like a semilunar form of this structure. Right ventricle septum surrounds somehow the left ventricle. Now we will dive a little bit more into the endocardial real heart structure surface. So you can see again area projection, and I remove right atrium lateral wall and right ventricle lateral wall, and just briefly show you the difference between the smooth venous part between the superior vena cava and inferior vena cava, and trabecular part in trabecular part of the right atrium. So this is two different parts of right atrium. The third part which we can divide, it's so-called vestibulum, from tricuspid valve till this trabeculation part. If we take a look on this specimen without lateral walls of right and atrium and right ventricle, what we can see here, this is superior vena cava, inferior vena cava, right atrial appendage, fossa ovalis, coronary sinus, tricuspid valve. And now we have to discuss where the sinus node is located. The sinus node is located usually in upper part of the crista terminalis. Crista terminalis can be very good recognized in this specimen. We can see the atriums in LO projection now. This is a right atrium, this is a left atrium, so this is superior, inferior. And then what we can see here. So first of all, we can recognize the venous part of right atrium, trabecular part of right atrium, right atrial appendage here, and this is a crista terminalis. This is a so-called C-shape structure which play very important role in impulse propagation through the lateral wall of right atrium. If we take a look with the trans illumination, we can nicely see again the difference between the venous part, smooth venous part of the right atrium, trabecular part. You can nicely see the difference in the thickness of the wall in this part. This is a musculus pectineus, and in between the myocardium is pretty thin here. You can nicely see it. And the crista terminalis, this is a thick structure. Again, the sinus node is located here in upper part of crista terminalis, in between the superior vena cava ostium and a right atrial appendage in this area here. This is usually from 1 till 2.5 centimeter length, and interesting that some cells with the properties of the sinus node can be located along the crista terminalis. Now I show you LO projection we can see left atrium here, right atrium, dissected on the level of the mitral valve annulus and the tricuspid valve annulus. What we can see, this is a right atrial appendage, this is a left atrial appendage, and this is endocardial smooth surface of the right atrium, crista terminalis here, and trabecular part of the right atrium. Again, with the trans-illumination, we can nicely see this difference between smooth part and trabecular part of the right atrium. And sinus node is located here in upper part of crista terminalis. Now we have to discuss the main ways of impulse propagation along the atrium. There is no any specific conduction system in the atrium, but we can divide some preferential ways of impulse propagation. So this is again crista terminalis, where the cells is located parallel to each other, and they will propagate impulse a little bit faster, about 20% faster along these fibers here. So we also know this so-called Wenckebach pathway and bundle, which going towards to the AV node. And then the next, this is a so-called Bachmann's bundle. Again, you can see it's pretty fast from crista terminalis. I will make some trans-illumination to see it better, and we can see that from sinus node, which is located here, the fibers is going very fast towards to Bachmann's bundle, actually towards to the left atrium, anterior superior wall of the left atrium. You can see that this bundle can be thick and wide, and we can see in different specimens, which is here. This is a very wide structure from this point to this point, and we can measure it, and you can see it's actually almost 2 centimeters wide, and this is also pretty thick structure. It's also interesting that actually the atriums, they connected only in some specific points. As we already discussed, this is a Bachmann's bundle here, and Bachmann's bundle main way of impulse propagation to the left atrium. Then we know that some impulse going through so-called the coronary sinus bundles, and they can play a role when this is Bachmann's bundle already fibrotically changed, or in other disease. Now we going deeper into AV node and his anatomy. Again, we are in the area projection. This is superior vena cava, inferior vena cava, fossa avalis, coronary sinus with the T-basin valve here, and tricuspid valve with septal leaflet. If I put the light here and trans-illuminate membranous septum, which is our orientation for his bundle, then we will better understand all the sides of the Koch triangle. So the his bundle is located here, just below or on the lower part between the membranous septum and muscular septum. actually within the fibrotic part. Just below is located compact part of EV node here. Slow pathways is located here along the tricuspid valve. Fast pathways along the tendon of Todaro and Eustachian ridge and anterior limb of fossa valis. So the tendon of Todaro within the Eustachian ridge, which is here, is one side of the Koch triangle. Tricuspid valve annulus, another side, and the third side, the cornu sinus. This is Koch triangle. Koch triangle help us to understand the location of the conduction system in atrium, so AV node and his. Now we will take a look on Koch triangle in LAO projection. So this is a cut in LAO projection. We can see here left ventricle, mitral valve, aorta, tricuspid valve, right atrium, and inside the left atrium. If we can see here, I will show you closer this structure here, which is membranous septum. As we already discussed, the His bundle is located here in the lower part of membranous septum, in between the membranous septum and the muscular part of the interventricular septum. Here we can see tendon of Todaro and the Eustachian ridge, cornu sinus, and tricuspid valve annulus. This is our Koch triangle, and the compact part of EV node is located just below the His bundle. The next part of the conduction system after His bundle is a right bundle. So in this specimen here in aerial projection, we can see right ventricle, right atrium with the fossa valis here. This is already aorta, and we can see the septal leaflet of the tricuspid valve, and we know that the right bundle is going inside the structure which we call trabecular septum marginalis. And this is anatomical border between the right ventricle outflow tract. So above this structure is the right ventricle outflow tract, and then this is the rest of the ventricle, and the right bundle is going inside this structure towards to moderator band. Moderator band here the catheter partially, so this is a moderator band. This is also important that we need to understand that first connection with the Purkinje fibers will can be found here in the border between the septum marginalis trabeculation and the moderator band, so in this area here. Some fibers still going towards to anterior papillary muscle, and some already connecting with the Purkinje fibers and then with the working myocardium. If we take a look on this specimen, this is opposite to LAO projection view, so from the atriums, and this is a right ventricle, this is a left ventricle. We can see that this is a trabecular septum marginalis here, and right bundle is located here inside its trabeculations, and then again it going towards to moderator band, and first connection with the Purkinje fibers in this area, but some fibers going towards to papillary muscle, anterior papillary muscle, and posterior lateral papillary muscle. Our goal of conduction system is activate papillary muscle earlier than the rest of the myocardium. To understand better a right bundle, we can also take a look on this specimen here. This is our AP projection, right ventricle, left ventricle, LAD artery, interventricular groove, and what we can see, this is anterior septal papillary muscle, which sometimes can be called musculus lanzisi. Here our membranous septum adheres, and within this projection right bundle is coming. And as you can see nicely in this specimen, that the right bundle coming within these trabeculations and then towards to moderator band. And moderator band very fast connecting with the anterior papillary muscle and through other trabeculations to other papillary muscles. For a better understanding anatomy of the left bundle branch, we will start from this specimen here. Again, this is a part of membranous septum, and the his is located here just in between the membranous septum and muscular part. Then left bundle is going towards to left endocardial septal surface, subendocardially, pretty wide, and then can be divided usually on 3 fascicles. Posterior, which is actually located inferiorly, anterior, which is actually located superiorly, and the septal. Let's see a little bit more carefully the left bundle branch. On this specimen, what we can see, this is the left ventricle, mitral valve. On this side, we can see the right ventricle and a tricuspid valve. This is aorta with the left main LAD, so this is the septum. And what we can nicely see that in this specimen, that some areas are wider than others. What it means, in this specimen we can nicely see not conduction system itself, but connective tissue which surround conduction system. So these white areas looks like a cables. This is a conduction system. If we more carefully take a look on the left bundle, from this view we can see that it comes from the area membranous septum, which is located between the right sinus valsalva and non-coronary sinus valsalva, and it comes with a very wide area, and this is a proximal part of a left bundle branch, and then it divides on several fascicles. This is anterior or superior fascicle. This is inferior or posterior fascicle, and this is a septal. What we can see nicely that these fibers can divide itself, but then can be again connected. So in between these fibers we can see the areas with just myocardium without conduction system. If we would like to better understand the direction of the conduction system and of fascicles, again we just have to imagine that the conduction system activate first papillary muscles, and we can see this is anterior direction of the anterior fascicle or superior fascicle towards to anterior lateral papillary muscle. This is posterior or inferior fascicle towards to posterior septal or inferior septal papillary muscle, and then the septal towards to the septal area. So what we can see, this is trabeculations and smooth part, and all these trabeculations full of Purkinje fibers. Now we will discuss the coronary arteries of the heart. So let's start where they begin. This is aorta, bulbus of aorta. We can see here right sinus valsalva and the ostium of the right coronary artery, and here we can see the left sinus and ostium of the left main and non-coronary sinus. So what we can see here, this is the left main, which divided on the LAD artery, left anterior descendens artery, here, which going just behind the pulmonary artery, and then towards to interventricular, anterior interventricular groove. The second branch is circumflex artery, which going around just below the left atrial appendage, actually just on the area which we call landing zone for occluder, and then it's going around in atrioventricular groove and supply lateral wall and posterior wall of the left ventricle. Sometimes posterior wall of the left ventricle can be supplied by right coronary artery. Right coronary artery is here, so you can see here between the right atrium with the right atrial appendage and right ventricle. It's going in this way and then towards to posterior interventricular groove. The coronary arteries on this specimen, this is aorta, left sinus valsalva, right sinus valsalva, non-coronary sinus, and a left coronary artery, left main, it's here, which divided on LAD artery, which is here. We can also see here intermediate artery and diagonal arteries. This is a circumflex artery here, just below the left atrial appendage, and then we can see it supplies a lateral wall with obtuse margin artery, and then it going to posterior wall, then a right coronary artery, which is between the right atrial appendage and the right ventricular outflow tract, then the right ventricle, and going here. It gives some branches, including a branch to the acute margin, which is here, and then it's going to posterior interventricular groove. Now we will discuss on this specimen the venous system of the heart. You can see it's in blue, these vessels in blue, this is a venous system. It's also plastinated and filled with the blue silicone. What we can see here, this is a coronary sinus. It's interesting that in AP lab we pretty often call all this structure coronary sinus, especially when we put within the CS catheter. But anatomically it's not really correct. The coronary sinus is a structure in between this area here where a Wiesen valve is located and also where the vein of Marshall coming into the vein system and the Thebasin valve from other side. The difference is pretty remarkable. You can see that the coronary sinus is covered by muscular fibers and great cardiac vein usually not covered by muscular fibers. So if we take a look on the other veins, you can see that they are coming from the surface into the coronary sinus direct or the great cardiac vein, and now we will see in different projection how they looks like. If we take a look on LO projection, then we can divide them on anterior interventricular vein. We can also say if they located in this area here, anterior lateral veins, then lateral veins, then a posterior lateral on this surface, posterior and middle cardiac vein here. From the point of view in relation to the base of the ventricles, we can divide them on a basal, mid, and the apex veins. Of course, what we can see that some veins can start it on, for example, posterior lateral surface or even posterior surface, and then going to the lateral surface, like this vein here. You can also see the diameter of the veins. Some of them really thin, and if we measure, it can be just 2 millimeters or pretty thick with a diameter till 4 and 5 millimeters. What we also can recognize, the course of these veins can be also not just the direct, which for us, for CRT especially, can create some difficulties. We can also see that some veins are coming into the great cardiac vein from different surface, from a lateral surface or from inferior, or sometimes even from the medial surface of the great cardiac vein. Another view on veins can be done with this specimen, which was cut in LO projection. But what we can see here, this is a coronary sinus. Here already great cardiac vein. This is a mid cardiac vein. This is posterior vein. This is a lateral vein here. Nice, can be seen here. And then anterior lateral and anterior interventricular vein. With this specimen, we can also nicely understand the relationship of the vein with the myocardium. In this particular specimen, this vein is nicely located on the lateral wall of the left ventricle. It doesn't have any fat tissue in between the vein and the left ventricle compact myocardium. In the same time, we can recognize that this is epicardial structure. So it's located on epicardial surface of the left ventricle, which not always optimal in terms of impulse propagation. We can also imagine if this vein is located just on lateral side of the scar area. Imagine this is a scar is located here, then it's even more can create difficulties in pacing and delay in activation of this part of the ventricle. So again, we can see it in different cuts. This is a lateral vein here and a relation with the left ventricle. In the same time, if we take a look on another specimen here, first of all, we can see that there is no thick vein on this side, on the lateral side. So this is a left ventricle and LAO projection in this case. And what we can see that in some veins, in between this vein and myocardium, we can recognize a fat tissue, which of course will be obstacles, so barrier for impulse propagation, create the higher threshold when the pacing is from this vein or from this vein. But in this case, in this patient, you can see this lateral vein with a small diameter, but enough to implant the lead inside this vein, but it's really conducting the myocardium, compact part of myocardium, and can be used for cardiac resynchronization therapy. When we implant, we sometimes can have a problem in catheterization of the coronary sinus due to T-Basin valve. In this case, T-Basin valve is pretty small membranous structure and the coronary sinus almost fully open. So what we can see, this is area projection, superior vena cava, inferior vena cava, fossa ovalis here, tricuspid valve. This is a left ventricle, and we can see this is a little bit damaged. The T-Basin valve, and we can see this fibrotic tissue here, and it's almost fully covered the entrance to the coronary sinus ostium. Just below here is we can locate so-called subT-Basin pouch. So the pouch, which actually can be perforated with a very aggressive tries to catheterizate the coronary sinus. If you are not within, so if you go with your catheter here, within this pouch, we can perforate this pouch with the instrument. If we try to understand where the coronary sinus is and a great cardiac vein is located, first of all, within this surface, we have to recognize that this is posterior to the ventricle structure, but it's anterior and inferior compared to left atrium structure. We can also see that this lay on the atrium level, so the mitral valve level is approximately at this line here. So it means the coronary sinus and great cardiac vein is located just on the atrium level. Sometimes we can have a problem with the Wiesen valve, which is located on the border between the coronary sinus and great cardiac vein. It's not always can be seen, but if it exists, this Wiesen valve, then we have to be very careful with our instruments, because again, aggressive manipulation with the catheter can create dissection at this level and be a reason of their different problems like hemipericardium. For CRT, we know that this mid part lateral wall of the left ventricle can be optimal in most cases for cardiac resynchronization therapy. It's interesting that in this particular case, this vein is located more posteriorly, but this is also can be nicely used, especially if the right ventricle lead will be implanted in the right ventricle septum.